I'm Linda Resnick. I'm the Director of Learn, and I'm pleased to introduce today's presentation in our series, Using Health Systems Research to Revolutionize Rehabilitation Care. If you'd like to enable closed captioning for the webinar, there are two options in the Zoom navigation bar. You can either select Show Captions if it's visible, or if it's not visible, you can select More to access the closed caption feature and then select Captions. Today's Grand Round follows a webinar that was presented by Dr. Gretchen Piat called Breaking Down Learning Health System Silos, the Vital Role of Inclusive, Accessible, and Adaptable Teams. You can view this and our other archived presentations using our link in the chat. Our speaker today is Dr. Stephen Hunter, Director of Internal Process Control for Intermountain's Rehabilitation Services. Dr. Hunter leads a team of internal process control coordinators and works closely with Rehabilitation Services Director of Research to establish a culture of quality and to standardize evidence-based care across rehabilitation disciplines and services. Dr. Hunter received his Bachelor of Arts in Physical Therapy from the University of Utah in 1984 and his clinical doctorate in 2008. He began working for Intermountain Health in 1984, and he is currently co-investigator for the PCORI OPTIMIZE chronic low back pain trial. He speaks nationally and has authored or co-authored manuscripts establishing the value of physical therapy and implementing research within a learning health system. Dr. Hunter's talk will be followed by a question and answer session. We ask that you please enter your questions in the Q&A feature of Zoom so that we can address them once the talk concludes. And after the presentation, we will have a couple of poll questions, which we'll want you to keep your eye out for so we can understand who's in the audience. And then we'll ask for you to help with our evaluation and then share some upcoming Learn events and opportunities. So with that, I'm pleased to introduce Dr. Hunter to unmute and share your video and your slides. And he will be presenting It Takes a Village, team-based clinical research within a learning health system. Thanks.
Okay, thank you, Linda. We'll get the slide deck up here. All right.
Perfect.
I think we're good. Okay, so first of all, I'm really, really happy to do this presentation. I appreciate Learn asking me to do this. As you all know, when you prepare for something like this, it's something you self-reflect and you learn yourself. And as I went through this, there was a lot of things I was like, oh, we could do better in that area, this area. And so I appreciate this opportunity to review this and to share with you a little bit of our journey, as well as how our team has come together over the years and what the team is currently. And I hope that by doing this, you'll be able to learn some things that you can gather from this. And I know that there's some individuals on the call that are doing great work, and it'd be great to hear about what you're doing when we get to the Q&A. All right. So no disclosures that I have. So here's kind of what I'd like to do today. Talk a little bit about Intermountain Health and then talk about the power of a team. And I'm going to use an example, a non-medical example, talking about these 4 C's of successful teams. And then I'll go through the Intermountain history and how we've tried to apply this and some principles that we've used in our journey. And then talk about the team members, what the village is with Intermountain. And I'll give examples of what those team members have done. And then just end with some examples of some of the research, kind of the result of what this team has done. Okay, so Intermountain Health is a not-for-profit integrated health system based in Salt Lake City, recently merged with the legacy SCL, faith-based Catholic system, which is now created, I think, it's about the 7th or 8th largest nonprofit healthcare system in the country. We have 60,000 employees, and 2,000 of those are rehab services caregivers. Okay, so you've seen this up in the upper right, the learning health system, learning cycle. And what I thought I'd share is what's in the center is Intermountain's operating model and how they really have tied in this learning health system into the operations that we do. So they have three different areas: align and see. So this is very similar to taking data and applying it to knowledge. We look at how success is measured, how we contribute as a system, and how we can focus on quality improvement. And then the next area is engage and improve. And this is very similar to kind of the knowledge to performance within the learning cycle. And that's where team members are responsible to really drive improvement. And lastly, learn and share, which is taking kind of the data or the knowledge or the performance and going back to using the data to continue the cycle. And it, on the Intermountain side, it helps us ensure that the best practices is being identified and applied. Okay, so I found there's lots of different things that you can find that relate to what principles are aligned with a successful team. I like this one, 4 C's, so that you can remember those easy. So the first one is clarity, to have a clear mission and vision statement. And then commitment is that the team follows that mission. They all understand it and they work toward that with a common purpose. Contribution is that everything is results driven. And again, that's core to the Learn organization, is that we use a lot of data to drive results. And then lastly is concern. And this includes things like transparency and being willing to take a hard look at yourself and say, hey, we didn't do so well in that area, or we made a mistake. How can we improve that in the future? Communicate that to the team and then be accountable so that everybody's accountable to say, we recognize we've made a mistake or we can do something better. And then you apply that in this continual cycle to get better. So what I'd like to do is take this example of Apollo 8. So I read this book earlier this year, Rocket Men, which is about Apollo 8. Now, most people are very familiar with Apollo 11 that landed a man on the moon, and Apollo 13, which was, the rescue kind of mission that they did. But Apollo 8 really was the first flight to the moon. They didn't land a man, but they navigated around the moon, orbited around the moon, and then returned safely. And the interesting thing about Apollo 8 is there were so many firsts that happened with this mission. It was way more dangerous, in my opinion, reading about this than Apollo 11, because there was so many unknowns. So this occurred over Christmas time in 1968. The adapted Saturn V rocket had failed tests earlier, and they really hadn't had a completely successful test of this rocket before this mission. There was not spacecrafts that were manned that had left the Earth's atmosphere, so they really didn't have experience in deep space communication. And for those of you that either were alive like I was or studied U.S. history, 1968 was not a great year. Martin Luther King and Robert Kennedy were both assassinated. They had the riots at the Democratic National Convention, which did not go well, and the Vietnam War was in full force. And what was also happening behind the scenes within the space program is the race to the moon with the Russians. And this weighed on a lot of people that were working in NASA. And so what NASA decided to do was compress a year of preparation for this mission into 4 months. And there were really a lot of unknowns even 4 months before the mission, which seems crazy. So let's talk about the 4 C's. Number 1 is clarity. I don't think there was any more clear of a vision for NASA than there was at this time, because Kennedy had said that the U.S. should commit itself to achieving this goal, famous quote, before the decade is out, of landing a man on the moon and returning him safely to the Earth. So that vision was clear, I think, with every NASA employee and probably most Americans. So the next one is commitment. certainly commitment by the entire NASA organization, but particularly these three astronauts, Frank Borman, Jim Lovell, and Bill Anders, who really, again, there were so many unknowns. One of them even had video recorded a message for his wife in case that they didn't make it. They could be played at his funeral. So, but fortunately, this was a 500,000-mile journey. It was successful. The Saturn V performed flawlessly. Deep space communication was excellent. And it was really, I believe, because of this team and the things that they did. So the last two C's, contribution and concern, as it relates to this mission. Now, on you can see on this slide, this is an iconic photo that was photographed with Apollo 8, which is the first time man had seen a moon or an Earth rise over the surface of the moon. And so they photographed this in color. And again, it's pretty iconic. So teamwork, I mean, it's as Andrew Carnegie said, it's the fuel that allows common people to attain uncommon results. And again, one of my favorite authors, poets, Margaret Mead, never doubt that a small group of thoughtful, committed people can change the world. Indeed, it's the only thing that ever has. Now, I'm not saying that the work we do at Intermountain compares to getting, men around the moon, but the concepts and the principles of successful teams, I think, have applied. Now, this is the ugliest, busiest slide that you'll probably ever see, and it's not for you to interpret. It's to help me tell you a little bit of a story of a history of how Intermountain's team has grown. This started in 1997 when myself and another researcher in the community, Gerard Brennan, started to collaborate on some research ideas. Gerard was not working for Intermountain, he was in private practice, and we wanted to do some things related to low back pain and cardiovascular exercise, which is what he had done his PhD work on. Well, as things would happen, Intermountain ended up hiring Gerard. And the intent was to have us do research. But as all things go, especially in a nonprofit organization or a for-profit organization, when you hire somebody that doesn't generate revenue, that is not easy. So when Gerard was first hired, he was only hired 1 day a week to do research, 4 days a week to work in the clinic and see patients. And fortunately, we were able to work together and collaborate as we were seeing patients. But that started in 1999. It wasn't until 2000 that we started really this concept of measurement, and it started with collaboration with the University of Pittsburgh and with Tony DeLito and Dick Earhart, and Julie Fritz was at the time there. And Gerard went back to Pitt and started to talk to them about how we could work together. And I think this is key to understand that a lot of relationships start with collaboration. What can we do together? What do we have in common? How can we help each other? In 2001, we started an outcome collection system, and we developed a tool where we could collect outcomes internal to Intermountain. And we put a team together to do this. And it was interesting, as I went back and looked at some notes, I didn't realize this or had forgotten this. We selected 5 outcome tools in outpatient orthopedics, and we entered 9 patients into this database in 2001. 2002, we added another 5,000. We got this thing rolling. We started to identify ways to group patients, which we call classification, so we could compare apples to apples. At the time, I was operationally managing 10 clinics, so we piloted it with these therapists. We made some mistakes in this area, particularly related to grassroots. We kind of did this and said, this is what you will do. And, we've changed that to really get more input from our frontline caregivers. But it started to roll, and we started to do some national presentations. We worked on a randomized trial, which I'll talk about later. And this is where Julie was involved with us from Pitt. Over the next several years, Julie moved to Utah. We contracted for her a day a week, and later, as things went on, 2 days a week. We started to involve our caregivers in some of this research and some of this continuous quality improvement. During the period of 2008 to 2013, there were 30 manuscripts published with ROM's data. We made ROMs available to people outside of Intermountain commercially. And in the last 10 years, we've developed to where we have a full-time researcher. That's Kate Minnick. It was Gerard, and now Kate. We formed this internal process control team that I'm involved with, which is 5 full FTEs to just implement care processes, implement other processes across our system. We expanded the ROMs from outpatient orthopedics to home care, lymphedema, vestibular, started collecting the AMPAC and Johns Hopkins highest level mobility in our acute settings. We were able to be involved with 2 PCORI funded studies, 5-year studies. The first, the Target study, led by Tony DeLito, and now we're finishing with the Optimize trial, which is in the last year, led by Julie Fritz. And then currently, you can see this as a journey. This is over 20 years. And as of this month, we have about 800,000 patients in our outcomes database, which we call ROMs. Over 4 million outcomes are in the database now, and we add about 6,000 new patients every single month. It's become part of the process of what we do. The collection rate and classification rate is extremely high because it's part of our daily work. And the other thing that's nice is we have generally 15 to 20 national presentations by caregivers, not researchers, but caregivers that have submitted abstracts or different submissions to present nationally, which is a great tribute to Gerard and Kate. Okay, so I'll get back to this, but I really wanted to make the point that where we're at today, I've talked to people and they're like, oh, Intermountain has so many resources, I wish we could get those resources. And what I wanted you to know is we didn't start with those resources. We started with 1 day a week. We started with grant funding that supported a lot of the people that worked in this group, and then it's just evolved over the time. So I really believe that if you have a vision and you have a process for what you want to accomplish, the team you want to put together, be patient. It can take time, but generally, if you're persistent and you have support, this can happen. Okay, so there's some principles related to our current operations in research and in clinical integration here at Intermountain. And I'm going to cover these 4, and I'm going to give examples of those. So the first one that we try to do is integrate data into everything we do. Again, this aligns so well with what Learn does. We collect and report on as complete of data as possible. We're transparent, and we report the good and the bad. I'll give you an example of that. And we've been persistent. The behavior change, particularly with providers, with caregivers, just takes time. I'll give some examples of that. So another busy slide. Don't expect to see this other than to know this is a list of all of the dashboards that we have and we currently use in rehab services. Now, some of them we use more than others, but this is the idea that we integrate this data into everything we do. There's dashboards related to our inpatient rehab, our home care, our acute, our EMR. We even have a dashboard that tells us how many people access our dashboards. So a dashboard for a dashboard. But this is just an example of how we've integrated this data into almost everything. So the second principle was collect and report data on as complete as possible. This is the first dashboard we did back in 2001. And it was simply, how are we doing at getting data into this ROMS outcome application? And this is data from the last year, which shows entry of about 130,000 patients. And those that were getting 2 or more outcomes is about 95%, and classifying at a rate over 95%. And this, we focused on just our caregivers, our rank and file in the trench individuals who are entering this outcome data. We really only use this, the entry as a goal, as the only goal for about 3 years. We didn't even look at the outcomes as goals. We just said, we want you to make sure you're getting this data as complete as possible, because if you don't, nothing else really makes a difference. We can't really trust the data. Okay, so be transparent. Okay, so this is a study that was published in 2007. And what we really wanted to do is look at our own therapists and if they were adherent with applying active approach and active care to low back pain. And the only way we could do it at the time is really look at the codes we were billing. So we were looking to see, are we billing at least 2/3 of the codes in active therapeutic exercise, therapeutic activity, patient education. We looked at, are we just using manual therapy in the first few weeks with back pain, the acute phase, and then not doing it as they become more chronic? And if an individual used more modalities, especially if over 1/3 of the treatment was more modalities, then we call that non-adherent care, or not evidence-based. Well, as we looked at this, what we realized is we were not doing well at Intermountain. Only 40% of the patients treated between the years 2002 and 2005 by Intermountain therapists were receiving what we deemed as adherent to the evidence. So 60%, more than half of the patients, were receiving treatment that we didn't feel was evidence-based. This was not good, but no one else had published on this before. And so we were like, let's put it out there, and then let's do better. And so this is a study that began what we affectionately call here airing some of Intermountain's dirty laundry, so that we can learn from it and others can learn from it. And fortunately, we've improved in this area. So, okay, so persistence, because behavior change takes time. This is from a dashboard that we use that is called a failure to progress dashboard. And essentially the orange line across the top is the average number of visits with an episode. And then the blue line is what we call the failure to progress, or it's the percent of patients who fail to meet a minimal clinical important difference for whatever outcome we're looking at. This happens to be total knee. So we're using the knee outcome ADL survey developed at Pitt. And it's the percent of patients who aren't making at least a 10-point change on this scale. So we want to reduce that. We want that to go down. We want the failure rate to go down. And what you can see is that prior to 2013, we averaged about 23% of our patients that were post-op TKA that didn't meet that 10-point improvement, which is not very good. You can see that that's improved over the years, but it's taken really a decade. A great example of just persisting, continuing to work on this. In 2017, we saw it get worse, and so we refocused and did a lot more chart audits and a lot more education with newer therapists to come on, and then you can see how that's continued to go down. So I think this is a good example of persistence. Don't expect to change things overnight, especially provider behavior, because it takes time. Okay, so now let's jump into the village that has been created here to help with this clinical research. I used a picture here. This is if some of you are familiar with this is a Maasai village in Central and East Africa. I use this because I volunteer time every year and I go to East Africa and help provide wheelchairs to individuals at no cost to them. And so I visited the Maasai village, and believe me, there's important roles of the village, just like there are very important roles here at Intermountain Healthcare. The first major role is the frontline caregivers. Okay, so very important that our frontline caregivers are an important part of the team. This is one of our caregivers, Michael Nelson, who submitted. He was working in the clinic full time, and on his own time worked with Kate to submit 2 abstracts to combined sections and presented earlier this year. And so I had to take this picture of Mike in front of his 2 posters. A great example of how we've tried to engage caregivers in our clinical activities and continuous quality improvement. So they make up what is, Intermountain has developed a system which involves work groups, and it's called a clinical practice model. And we have probably 20 different work groups. We have a hand work group, a spine work group, a speech therapy work group, and these groups really generate a lot of the ideas for us to make changes in both our EMR, in treatment, and in practice changes. And Mike is a member of a couple of these groups, one being our spine group, and also helped us develop changes with the way we collect data in our neck pain patients and our EMR. And we don't set aside time for these caregivers to to be in these work groups. They do it outside of their clinic time. Their clinic productivity is expected to stay the same. So this is early, late lunch meetings, and again, really core to what we do. This is another example. This is an occupational therapy group. I met with this group. We meet monthly, and we had our meeting yesterday. And so we're really looking with our occupational therapists as to what are the conditions that they see, what are the classifications, and then right now we're piloting what are the outcome tools that they use, and so that we can get some of these outcome tools into our automated ROMS database. A wonderful group with some wonderful OTs that are fully engaged. We met during their lunch hour yesterday. So the next village people, or the group in the village, is the team that I work with closely, the internal process control team. So this is 4 full-time therapists in addition to myself and an auditor. And these are the boots on the ground. So this team is amazing. They travel around the Intermountain system. They gather information from direct caregivers. They do a lot of education. They do a lot of implementation. They lead a lot of these work groups or participate on them. You get information from our rank and file therapists. And some examples of what this team has done. We did all of the PCORI optimized behavioral change education for the Intermountain, the University of Utah, and Hopkins. We're working now with the University of Colorado in trying to do a study using neuromuscular electrical stim in the early weeks of total knee. This group, one team member has developed a vestibular care process model that we use throughout our system. One team member has implemented the activity mobility program in our acute setting, the AMP program from Hopkins, by measuring the AMPAC and the Johns Hopkins highest level of mobility, and translating that over into nursing. And then also we have a caregiver, our technology caregiver, Kevin, who is working on selecting a virtual vendor for the entire Intermountain system. So these are just some examples of what this team does and works on every year. So Kate Minnick is our director of research. Gerard was prior to that. Kate's a member of the Rehab Services Senior Leadership Team. So it's good that our leadership values a research director on equal terms with any other director. She performs all the research, directs all the research performed in rehab services, sits on Intermountain's research leadership team. And prior to her, Gerard did, and then a physical therapist or a rehab professional had never sat on that research team before. She prioritizes the initiatives, works closely with the internal process control rights grants, and you can see here Kate that celebrating some IPC team members. So this is an example of Kate's work. This was a study published earlier this year in JOSPT, looked at over 12,000 total knee patients over 10 years. And again, I mentioned this earlier, looked at this failure to progress rate improving. But the other thing that we found with this study on the left side of this, or the right side of this slide, is the variation, unwarranted variation reduced significantly, particularly between clinics with this study. And that's what you want. In a health system, you not only want the improvement, but you want the variation so that people gravitate to a more evidence-based mean that gets better outcomes. And we found this with both of these studies that were published earlier this year. So a good example of case work. Okay, the next person on the team is Devin Woodfield. And Devin is our data analyst. So he's the one that's created all of these dashboards. He works with all of the services at Intermountain. He's again on the far right of the slide there, and also co-authors manuscripts, helps us write those, and presents nationally. And you might ask, well, how do you get a full-time data analyst just for rehab services? Well, this started 8 years ago when we just Gerard was writing Devin into grants. So we were getting his money, his hours paid for. And over time, that just developed to where individuals understood the value of what he was doing. And they said, hey, we just need this person full time. So again, patience with a process to get what you want, and just do it incrementally. So this is an example of Devin's work. This is what we call our patient-centered dashboard. This tracks individual patients through the continuum of care. So this is a total knee patient, and the vertical lines on this graph show that that there is surgeries that were done, 2 different surgeries. We collected pre-op data of the knee outcome survey, pain, 5 times sit to stand, and the tug, and it shows how that progresses while they were in the acute setting, and then in the home care setting and into outpatient. And so I'll just show you a couple of things with this dashboard. Again, this is representative of Devin's work. You can search for an individual patient. You can look at these outcomes, the knee outcome, pain, tug, 5 times sit to stand. You can filter based on location. If you want to see what one hospital compared to another, or one location compared to another location, you can view the team so that you can communicate with a therapist in home care when you're in the outpatient setting, and who saw them. And this is something we can always do better at, is communicating across our team. You can look at these trends because of the line graphs. There's a legend that looks at different settings, and you can, again, get this recent surgeries. So great example of what Devin's done. So I'm not going to go through all of the other team or village members, but we've got administrative assistants, caregivers. We work with a value-based organization to do contracting for value. Again, data analysts. We work with data architecture. They really do a lot of the work that sets up Devin to be successful. We wanted to make sure I acknowledge them. We work with Learn Scholars, which is, we've had several Learn Scholars. We have one currently, Broca, that's an occupational therapist and just brilliant, that's working with this occupational therapy team that I mentioned earlier, rehab nursing, physicians, and leadership. It's just a wonderful village that helps us accomplish what we want. So I want to end here, not end, but I'm going to, over the last 5 or 8 minutes before we take questions, I want to just show you some of the results of what this team does. Again, I'm kind of ride the tailcoats of this group, but these are just some research examples that have been published. So this is one of the first in 2006, a randomized trial looking at subgrouping patients with acute low back pain. Gerard was the lead author, but we have other authors here from Pitt. And this really looked at, within 4 weeks, the treatment, if we classified patients and matched treatment to that classification, even a year later, those that received matched treatment compared to those that received unmatched were still doing better statistically a year later. Great study, and Gerard won the Rose Award for that publication. We looked at studies specific to spinal manipulation. This was done in our occupational health setting, where we, again, looked at patients that were matched to receive a manipulation versus those that should have received the manipulation and didn't, and what the outcomes were. This was a study looking at the effectiveness of continuing education, where we used patient outcomes to decide if the clinical education that we did made a difference. And there was a couple of studies that were published on that topic. This was a study that were Darren Neely, who's the internal process control leader for our children's services, although this was done on orthopedic low back pain, where he worked with Stephen George and Jason Benechek on the OSPRO and that tool, and was it effective in helping predict disability improvements. This is a study done by another one of our team members, Jenny Marlin, looking at hip female hip post-arthroscopy hip patients and the outcomes over long term. We looked at total knee, and this is a study that found that the sooner we got patients after total knee into outpatient therapy, the better the outcomes. So the importance of early intervention and quick intervention into the outpatient side was found by this study that was led by Gerard. This is one of the several studies that have come out of the Target PCORI funded trial. This was authored by Dr. Joel Stevens and looked at risk factors from acute to chronic, and was published in JAMA. And then this is a study that's come out of the OPTIMIZE trial that we've been involved in with where Julie led this effort. And this was very creative. When COVID hit in the middle of this OPTIMIZE trial, Julie was able to transition and do some work to look at telehealth physical therapy for people with chronic back pain, and very creative work that she did along with the rest of the research team from Intermountain and from Hopkins. This is an example of looking at shoulder categories and classifications that Gerard did with Eric Prent and Josh Cleveland. And again, I'm showing you this, that there's a broad amount of research that's come out from total knee to back pain to shoulder, multiple things. This is a study, this is not in your notes. I just added this yesterday. A study that came out is come out ahead of print by one of our speech therapists, looking at feeding dysfunction with NICU patients and working with the University of Utah on this. Kristen Brinker is one of our speech therapists that helped to co-author this. So again, a lot of this and support for this type of research has come over this team working together for many, many years. Okay, so I'm going to end here with this summary slide, and then we'll take questions. So successful teams, just like Apollo 8, they follow agreed upon core principles. They align with this clear vision, and it's really important that the team members know what the clear vision is. And if you don't, if you've got to ask them. There's times where I've led teams, I thought, of course, the vision is clear. And then I asked the team, well, we're not really sure. So we need to make sure that is clear, that they share this responsibility and effort so that it's everybody working together. And again, they're accountable, especially when mistakes are made, that we recognize those, we communicate those transparently. And then we should always recognize team members and celebrate their success. So, Linda, I'm going to stop sharing and be glad to take any questions.
Well, thank you so much. It's such an impressive body of work, and such a example, I think, for many places across the country, what you can do when you have this clear vision and leadership and data infrastructure and will to use the data for research and quality improvement. And okay, so I think we'll begin now with a couple, we'll close the poll, and we can stop sharing that, but that's helpful for us to know who's here. The first question for Shannon McGrath says, this is really great. We appreciate the emphasis on a clear vision. As you grew your teams, how did you determine resource, time, and human allocation for team members?
So if I understand that, how did we determine the allocation for team
resource
members?
Like how did you, I guess, determine the resource allocation of time and people?
Well,
how did you determine your needs?
Yeah, that's a good question. I think, and early on, this kind of happened organically. As I mentioned, with the support that we had from a researcher that started with just 1 day a week. And I think one of the things that really helped is that Gerard was able to get some funding, right? We were collaborating with other people, and so they had some grants, and we were able to receive some grant money, and Gerard wisely distributed that to some of the resources we needed, which was one, a data analyst to help us look at the data, and two, a statistician. So early on, we allocated some of this grant funding to resource those individuals, and over time, it grew to where those, at least the data analyst, grew into a full-time position. I think Kate would probably answer this question better, because the director of research to look and say, when we do a study, what are we doing? How many sites are we going to do? And is that going to take some resource allocated to a site leader? And then what kind of a database are we looking at, and how big is that? And that will determine how many hours of the data analyst and the statistician we need. And then how long will this study take? So over time, and so that we can, allocate those resources over time. And I think this just happens on a case-by-case basis. Even though we do have some full-time people, we still have to allocate those resources to different projects.
Great, thank you. Another question in the Q&A, where is your outcome data or the ROMS data stored? Is it inside the EHR or in a different location? There's this a multi-part questions. So the follow-up is, do you have people on your team who are maintaining the data infrastructure, and how is access to the data controlled?
Oh, good question.
Lots of questions. So
Yeah,
first, where is it being stored?
Yeah, so first of all, it's stored separately in our enterprise data warehouse. So it's separate from the EMR. At first, I was like, that's probably not a good thing, because sometimes we have to pull data from the EMR and then pull it from the ROMS application. But to tell you the truth, I'm extremely grateful, because a month ago, we've been on a Cerner-based product, and a month ago it was announced that Intermountain would be switching to Epic. And if we had had ROMs within Epic, it would have been a Herculean task to change that and try to integrate that into, if it would have been in Cerner, it would have been Herculean to change over to Epic, while a system of 60,000 employees is switching. I don't think we would have been a high priority. So the fact that we can house it separately actually has become an advantage. Now, the dashboards that I shared with you are created in Tableau, which is a visualization product. So our caregivers they can't really tell whether this is in the EMR or not, because Devin pulls data from the EMR. This would be like demographic type data and cost data. He pulls data from ROMS, which is the outcome classification data, and puts that together in the visualization Tableau dashboards. So it's not a hindrance, other than entering data, outcome data. The patient reported is entered on an iPad that goes into ROMS. The therapist enters their functional data into the EMR, but it's on the back end that we pull that together. So it's housed separately, but integrated through an enterprise data warehouse, an EDW. And I think many of you are probably familiar with that term that allows us to pull data from multiple sources.
So I know there's one more follow-up question here, but I want to make sure we come back to the question of the dashboards and then the content of the dashboard. But the last part of that anonymous question was, how is access to the data controlled?
Yeah, so the data is not, access to the majority of the dashboards is not controlled. It's transparent. Any caregiver at Intermountain has a login that they can get into the ROMS database, and they can look at the dashboards on themselves. They can identify a colleague. At first, this was 18 years ago, we were nervous about this. And so we blinded everyone, and all they knew was their own data. In the first meeting we presented this to, all of the caregivers shared their blinded number. And they were like, we just want to know what everybody's doing. From that day forward, we made the data transparent. The only time we limit it is if a dashboard is in development. And so Devin will sometimes limit the ability to a certain team until we get it going. But if anyone requests access to any of those over 100 dashboards, we grant it, and people can go in and use it. So we don't limit access.
So regarding those dashboards, how do you decide what the content and format of the dashboards are? You have so many of them and they have different purposes. What's the process of developing one of those for rehab?
Yeah, so this generally comes through one of these teams. Okay, I'll give you an example. So we have a mobility team that looks at our acute care therapists, and again, we're collecting our physical therapists, occupational therapists, and speech therapists are collecting the three AMPAC 6 clicks for cognitive and for mobility and for self-care. And so those go in, and what we realized is we needed a dashboard so that these caregivers could go in and filter and say, how is our team doing at this hospital compared to the team at another hospital, and how are we comparing to the average? So they requested that Devin create a dashboard for the AMPAC, and they kind of had some ideas of visualization that they wanted to be able to look in a kind of a Pareto chart to look at the most frequent conditions, look at the volumes, so they could compare large hospitals, small hospitals, And so they just said, Devin, we would like you to create this. And it came out of that kind of a grassroots, we need to know this information. And that's how most of the dashboards are now. Devin gets lots of requests. So we have to prioritize, and it's usually the senior leadership team, which includes, myself and Kate, the acute care director, our IRF director, and the medical directors. And they will look at it and say, okay, Devin's limited on time. What are the priorities for the system? And I don't think we've ever declined creating a dashboard. Sometimes we just prioritize them differently.
Okay. I have a question from Louis Kazis. He would like you to comment on the cost effectiveness of the interventions or the studies regarding guideline adherence. Have you looked at cost?
Okay, so we just created a dashboard. It's still in pilot that is pulling claims data, and we can look at a year, 2 or 3 years of downstream claims data. This is brand new, so you must have been a bug on the wall or something, because we just presented this 2 weeks ago, and it looked at what we started with was we wanted to look at low back pain. And we wanted to look at physician adherence with the evidence. And so we looked at 4 themes. We kept it simple with non-specific, non-emergent, and we ruled out some red flags. So this is non-red flag low back pain, and it did include radicular pain, but non-red flag. So we looked at 4 things in that first visit. The very first visit, did that primary care physician, the ED physician, or our acute or early intervention, we call it Instacare physician, did they not order opioids? Did they not order imaging, any imaging, even x-rays? Did they not refer to a secondary source? And did they refer to physical therapy? So acute low back pain, did they not do 3 things, and they did do 1 thing? And then what we did is the dashboard looks at the downstream costs at each of those factors. And what we found is that the cost, as you might imagine, is significantly less when they refer on that first visit to physical therapy and they don't prescribe opioids, imaging, or secondary specialty referral. The biggest impact was the opioid one, by the way. And again, we're still gathering this data, but it was when they don't prescribe opioids in the first visit, the cost savings are half. It's half as costly as if they do prescribe an opioid.
Super.
So,
thank you.
More to come in that area as we work on that. But
so you and Intermountain, you have self-insurance, so you have all of the downstream cost data?
Yeah, so that's a good question, Linda. So we are self-insured, and we also have our own payer, commercial payer, but we also have data to any other patient that comes to Intermountain that's covered by another payer. So we're able to, we know what was billed for those other insurances and what the costs are for that. So we have a pretty broad, claims database that we've integrated into our outcomes.
And a somewhat related question from Peter McMenamin. Is Intermountain Health part of or integrated with an academic medical center? And do you have a formal academic clinical partnership with a local PT school?
Yeah, so Intermountain does work very closely with the University of Utah. So a lot of the residents at the University of Utah do rotations at Intermountain. We work very closely with 2 of the schools in Utah, the University of Utah Physical Therapy School and private school Rocky Mountain University, that's 50 miles to the south of Salt Lake and Provo. Those are the 2, but we take students from all, just about any academic, physical or occupational therapy or speech program that works with us. So we love and take, I don't know how many students we take a year, but we take quite a few.